for people who can't make these sessions to be able to watch them. So they will be uploaded onto the training website. So getting started then, medical conditions. We're going to go through and describe the anatomy and physiology of the endocrine and nervous system and talk about the relations to that. Talk about the pathophysiology kind of side of it and how that reflects and relates to some medical conditions and disorders. And then we're going to talk about the appropriate management of these medical conditions and disorders. So if you've joined the other sessions, as you know, we're trying to include a little bit more anatomy and physiology into it because we're trying to up the level of training and education that we're offering to you guys into a kind of a level 3 standard. So if anything does change in the future, it's very easy for us to adapt across to it. So first off then, let's hand over to you guys. What is the nervous system then? What do you know about the nervous system? If you want to put in the chat bar and let us know what the nervous system does, what is it made up of? Let's see what level of knowledge we're at. I know you've got a chat now because you've all put your names in. So it's a messaging service for the body. Yeah, good. So it sends messages, lots of different messages throughout the body and tells us what to do. Good. What else? What is it made up of? There are central and peripheral nervous system. Sends signals, conducts impulses, controls body function, connects the brain to the body, helps regulate temperature, nerves. Awesome. So yeah, we've got a good understanding of what it does and how it's so important. So the nervous system performs 3 main functions for us to carry out complex range of tasks, including controlling body movement, regulating our heart rate, regulating our temperature, like someone said, and creating memories and producing speech. Let me just going to mute Jerry for a sec. There we are. So it's just those 3 main things, and how it does it, we use our sensory functions, the perception. When we're walking, we can see a hole, or if we can see a different surface, then our perception kind of takes into account if we touch something hot. Information transfer and processing, someone said about messaging, and that's what that's all about. And then motor function. Jerry, have you got your hand up? Do you want to ask a question?
Oh, it's okay. I've had difficulty in joining in the session, and I didn't have anything on my screen. It's just appeared now, so I'll try and catch up with you. Thank you.
There you are. Awesome. No worries, Jerry.
Cheers.
So that is what the nervous system does, and they're kind of the main 3 functions of it. So the nervous system consists of the brain, the spinal cord, you guys know, and that is referred as the central nervous system, so the brain and the spinal cord. Then we've got the peripheral nervous system, which is made up of the 12 cranial nerves, which originate from the brain, and then 31 other pairs of nerves that originates from the spinal cord. And the peripheral nervous system kind of breaks down again to the somatic nervous system and the autonomic nervous system. So somatic is, you probably guess, is the sensory side of it, and the autonomic kind of nervous system is the regulation, so the breathing, our heart rate and stuff. So it's really important. It regulates our heart rate and our breathing and tells us when to breathe, and we talked about that in the first session. So looking at it then, recap, nervous system breaks down into 2, the central nervous system, the peripheral nervous system. Central is the brain and the spinal cord. The peripheral nervous system breaks down to the somatic and the autonomic nervous system, the involuntary and voluntary controls. So peripheral, the autonomic stuff, so that is the automatic stuff, so our heart rate, our breathing, which our body does automatically. That can break down further into our sympathetic and parasympathetic nervous system. I can't speak today. So para is, easiest way to think of it is our rest and digest system. So it slows everything down. Then our sympathetic is our fight or flight. So that is what speeds everything up. So if we see something, if we're scared, we get our fight or flight response, and that is what that is. Then we go to the Autonomic, which is our sensory stuff. So again, that breaks down to motor and to sensory. So this is what controls our movement. It allows us to move. It controls our musculoskeletal kind of system. So the brain will tell us to move my hand, and that will go down to my muscles, allow me to move. Sensory, if I touch something hot, then that will go straight back up to the brain, tell it's hot, it's danger, and then tell my motor to move away from it. And this is milliseconds, really quick. So the nervous system is really good, and it allows us to do multiple things. So when it's working good, and that's what we like. But when it's not working, then that's when we need to kind of go on and look into it. So we're going to talk about the brain, different parts of the brain then. So anyone want to name some parts of the brain? Let me get my chat up. There's my chat gone. So you guys name some parts, and I fiddle with my screen so I can have a split screen. Cool. Frontal lobe, parafrontal cortex, good. So we know, let me just right, so guys, let me move that back up. Cool. I'm just on a different computer today, so things are a little bit mixed. Awesome, very good. So yeah, you've mentioned quite a lot. So yes, the brain is split into different parts, and different parts of the brain allows us to do different tasks. Why this is important is when we talk about neurological conditions such as strokes, such as seizures, and it depends on what part of the brain is affected, depending on what part of the body is affected. And that's why we're going into it. So we're talking in this part A down the bottom is our visual and colour. What about B? What do you think B is? Anyone know? Perfect. Well done, Gayla. So yeah, so that is our perception, our kind of spelling, how our brain kind of works things out. Moving down is that frontal lobe, which is our main law of thinking, our planning, our organisations, where our emotions and behaviour control. So if we've got a stroke there, then we may just have symptoms of strange behaviour, such as aggression or anger, or dementia is the same thing. If the frontal lobe's affected, normally those patients will have different emotions or different behavioural patterns. Then we're going down to the temporal, which is our memory and understanding and language. So if we have a stroke in that section, then we may not have the classic signs of weakness. We may just be having a muddled up words or muddled up speech. And then we go down into the brainstem, which is our kind of control center that does our basic life functions, our breathing, etc. So really important to understand the brain, and different sections of it will reflect on different tasks or parts of the body when we're talking about certain conditions. So the main portion then of the central nervous system is the brain, which is within our skull. And they're the four main kind of sections that we're talking about. So again, when we're talking about head injuries and trauma, we're going off topic a little bit. But if we've got a base of skull fracture with those panderize, the bruising or fluid from the ears, then we know we've got a fracture down the bottom where our control center lies. And it's really important that we kind of manage head injuries patients with care, because we don't want to damage this kind of central nervous system, the lower part of that brain or the base of skull. So that is a really quick recap on the nervous system. What we're going to do now is relate that knowledge to different conditions. So what conditions do you think fall within the nervous system? CVAs, yeah, cool. I've talked about CVAs before, yeah. Parkinson's, seizures, convulsions, good. TIAs, stroke, dementia, MS. Yeah, some SVT, yeah, good. So we could have that neuro side of it, what's affecting it. ABC, the D part of it, yeah, good, okay. Any other ones? Cool, I think, yeah, we got most of them. So what we're going to talk about, we're going to talk about three main common conditions that you may come across. So vasovagal syncope. It's a strange one because people do refer this to cardiogenic, where there are two different causes to a classic faint or vasovagal syncope. So we've got a neurogenic cause, or we've got our cardiogenic cause. So anyone know what happens when someone faints? Any idea? I'm making you work a lot today, haven't I? What happened when someone faints? Blood flow, yeah, good. So the blood flow pressure drops. Lack of blood to the brain. Cool, good, excellent. So yes, it is due to a reflex. So bradycardia happens, and then that bradycardia includes peripheral vasodilation, which is provoked by either an emotional or pain or fear stimulant or standing up too long. And that is down to a neurogenic kind of cause, especially when we're talking about emotional or pain or fear. That is our fight or flight response in our peripheral nervous system. What else is important to note is the onset is over seconds. It's not instant, because someone who has a fainting episode or syncope has a pre-syncope phase where they have those pre-symptoms to a faint. So vasovagal, yes, occurs when a patient faints, and it's the body's overreaction to a certain trigger, such as sight of blood, extreme emotional distress, and it's caused by a cardiogenic kind of syncope. So you keep dropping out. That's okay. If you keep dropping out, we're going to record the session if you do miss anything. So a vasovagal syncope triggers vasovagal syncope trigger, so such as the extreme pain, emotion, causes that altered heart rate, blood pressure drops, vasodilation, which reduces the blood supply to the brain, causing a brief loss of consciousness. Usually harmless, doesn't normally need treatment unless there's an injury caused during the fainting episode. So normally it will last a few seconds, then they'll come round from it. So vasovagal syncope occurs as a part of the nervous system, which regulates the heart rate and the blood pressure malfunctions due to a response of a trigger, such as the sight of blood, which we talked about. The heart rate slows, blood vessels in the legs widen and dilate, which allows blood or fluid to pool in the legs, which lowers the blood pressure, which combines a drop in blood pressure with the slowed heart rate, reduces the blood flow to the brain, which causes a temporary faint or loss of consciousness, because the body hasn't got enough blood to the brain, so it wants to reset, allows the person to lie flat on the floor, which brings blood flow back up to the brain. Sometimes there's no classical kind of trigger to it, but the normal common ones are standing for long periods of time, heat exposure, it's getting too hot, seeing a sight of blood, emotional trauma, having blood drawn, and fear of bodily kind of injuries. So a lot of it is neurogenic, and they just kind of have that fight or flight response that causes altered heart, causes the part of the brain to malfunction, to interrupt the heart rate and the blood supply and the vasodilation of it. So recognition then. So we talked about that pre-syncope phase. So it's not instant. It will happen over seconds, and they may have these, or they will have this pre-syncope phase. So they will go pale. They'll have lightness. They may have tunnel vision. So they lost their kind of peripheral vision and they've just got narrow. They may feel sick. They may feel warm, cold, clammy skin, or blurred vision. And that will happen a few seconds before or a few minutes before. Then when they do have it, then the bystanders will notice, because they won't remember this, but they may jerk or have abnormal movements. Don't get mixed up with a convulsion, because again, this is only a few seconds and they recover. They'll have a slow, weak pulse because of their peripheral nervous system has malfunctioned, reducing the heart rate. They have dilated pupils because, again, the peripheral nervous system has malfunctioned, and we've got peripheral or vasodilation of our blood vessels, which dilate our blood pupils as well. So that's what's going on. How we manage it. Again, like I said, vasovagal episodes will last less than a minute. But if you stand them up too quickly, they've got a risk of fainting again. So let's not get them up too quick. Normally within 15 to 30 minutes, we can sit them up slowly. Old school, we can raise their legs as well. That may speed them up, feeling a little bit better, because we now know what is going on. We've got a pooling, we've got a vasodilation, pooling of fluid in the limb, lower limbs. So if we raise those legs, we're going to bring that back up to the brain and the vital organs, just to speed up the recovery. So treatment, positioning, lie them down, raise the legs. Fresh air is really good. Let's cool them off, because one of the symptoms, they're going to feel really hot and flushed. So by cooling them off and fresh air and reassurance, because it is that fight or flight, and then sit them up gradually. Give them that 15-30 minutes just to recover. Let the body reset itself before we sit them up. We don't want to cause them to go into have another fainting episode. So if they don't recover, then most likely they're going to be unconscious. So what are the causes of unconsciousness? If we can put it into the chat bar for us. Happens to you if you eat large meals, yeah. Classic Sunday, nice hot restaurant, and they've just had a big old Sunday lunch. Poisoning, hypoxia, diabetes, heart rate, medication, epilepsy. Cool. So I've recognised a few people in the rooms, and some are first aid instructors. So you're going to remember fish shape. So causes of unconsciousness is the faint or vasovagal syncope, and we know what's going on behind that now. Imbalance of heat, again, that can cause a faint through it. Shock, So loss of bodily fluid, reduce head injuries. Again, we've got that base of skull fracture, and then we've got that control center right at the back or bottom of our head or brain, affecting the central nervous system. Stroke, CVAs, heart attacks or myocardial infarctions, asphyxiation, poisoning, epilepsy, and diabetes. Nice to know, to be honest, and it somehow keeps getting into our PowerPoint. We can't get rid of it, but it's good. It's nice for us to remember reasons and causes of unconsciousness. So, everyone happy with a classic faint? And what's happening with it? And how we can treat it? You will come across it. It's getting hotter now, and we are going to come across more. So, epilepsy then, another condition that affects our nervous system. So epilepsy is a single condition, but it is used to describe other convulsions. So they may say they've got epilepsy, but there are other reasons for seizures as well, or seizure disorders. It results in a abnormal electrical activity to the brain, which produce convulsions or fits. How I was taught is a electrical storm in the brain, and it's those neuroreceptors aren't working and the body's not functioning properly. Sometimes the patient has got a history of fits or epilepsy, and they may wear Medi alerts that you may see, or it will be in their mobile phone under ice. But it's not always causes. Like I said, seizure disorders can occur through other causes. So alcohol withdrawal, hypoxia, head injuries, all those can cause seizures as well. So it's not just epilepsy. So what we need to know is the type of convulsions. So epilepsy is the term, is a medical condition, but there are different types of convulsions as well. So like I said, convulsions results from a excessive activations of those neurons in the brain or in the cerebral cortex. So those little neurons where they normally just send and receive, they're just going mental. And information isn't getting received or sent properly, which causes the patient to have a seizure. Convulsions or seizures are defined into two main categories. So we've got our partial or focal fits, which will affect one part of the brain, and then that can be split down further to simple partial or complex partial. Then we've got our generalized convulsions, which are tonic, clonic kind of seizures, as Ross has mentioned. So tonic and clonic and absent seizures. So what does that mean then? So let's break it down. So classifications. We've got our generalized seizures, which can be motor, which is our tonic, clonic, where they're using all their limbs and they're shaking. Or non-motor, which is that kind of atonic kind of seizures or absent seizures. Then we've got our focal. Again, that can be broken down to simple or complex. Simple is when they're aware of it. So this time we've got a disruption of those neurons in one part of the brain. So this could be just a shaking of the hand. And it's simple because they are aware that their hand is shaking, but they can't stop it. And then unaware complex is when they don't know it's happening. So that would be, again, potentially an absent seizure where they just drift off and stare. Again, both of those can be motor response or non-motor response. So shaking of limb or not, and it could be staring out. And that is the classifications. So generalized is the whole brain, focal is partial part of the brain, maybe just one limb or a twitch in an eye. Could be focal. Again, we talked about the different dimensions of the brain, and it's affecting one part. So this is an EEG. So if someone's had a seizure, they may have gone through this to find out what's causing it. So the top one is a normal EEG. So the neurons are working properly, and it's just a nice balance working through. Looking at the seizures at the bottom, we've got our focal, which is just affecting one part of the brain, which is the top. So that could just be the limb. Ross, if it's not working, if you drop out and drop back in, it may work back for you. So one part of the limb, let's say, is having a seizure, and the rest of the body is working fine, so they're aware of it. And then the generalized is where the whole brain is affected, and they're having that tonic-clonic seizure potential. So that is what kind of is happening in the brain. So it's really important. There's loads of different types of seizures or convulsions, and that we've got a sort of understanding on what sort of part of it and where in the brain it's affected. Other considerations then when we're talking about convulsions. So convulsions can be down to heat, that imbalance of heat. So febrile convulsions is a sudden increase in body temperature, normally in children, because children, they get hot due to infection. And unlike adults, we sweat, we can take layers off. Children can't do that. They can't regulate their temperature. So their temperature will rise until they have a febrile convulsion. So again, we need to have a good history. If the patient's warm, with a history of infection, then let's cool them down, because it could have been a febrile convulsion. Status epilepticus is the generalized convulsion. The whole body, the whole brain is affected, and the seizures last more than 30 minutes, or have a series of mini seizures with no recovery time between. If you notice this or go to this, this is a life-threatening call. This is a red call. So you need to let control know, so we can upgrade the response to you. Just say it's status epilepticus, and it's over 30 minutes, or multiple seizures with no time of recovery between seizures. It's life-threatening, so we need to identify it to our control. And it is normal to have a postictal phase. So if you run up and down the stairs, you're using quite a lot of muscle and activity, and you're tired afterwards. Seizures is exactly the same thing. They're using all their muscles, they're generating and using a lot of glucose and energy. So they will be tired after. So it is normal for them to have a phase of sleepiness, confusion, but it will recover after 15 minutes, or it could take a few hours. But it's important to get a history from the patient. But postictal stage or phase is common when they do have a convulsion or a seizure. So management of these conditions. Clear the space around them, prevent any further injury. 100% oxygen when they are actively convulsing, because it's on the red list. Once they've stopped fitting, we can reduce it down and give them supplementary oxygen if required. But when they are actively convulsing, we need to give them some O2. Constant reassurance. Note the time is really important, and how many convulsions and how long they've been lasting for. So document that down and hand it over to the crew. Don't restrain the patient. Don't physically put anything in their mouth or try and open their mouth. When the convulsions have stopped, manage the patient's airway. Remember our stepwise approach. The first thing we can do, and the most easy thing we'll do, is the recovery position. Get them over onto their side. And then, if required, we can give them oxygen therapy. Again, don't forget the oxygen guidelines do not apply to children, so they can just stick with their 100% oxygen because they have had significant illness or injury due to the convulsion. Cool. So that is epilepsy. So again, another condition. Depending on what part of the brain it's affected, it will be focal or partial. So if you just see one person twitching the arm, now hopefully you can refer that back to being a focal seizure and affecting one part of their brain. And that's what's going on. And again, simple, complex, they're aware of it or they're not. Also, one thing to know is the last thing that goes is their kind of sensory, their hearing. So I've had patients who have been unresponsive fitting, but they've heard everything I've said. So reassurance again is really key. Telling them I'm a first responder, I'm here to help you, you are safe, is reassuring. In some circumstances, they still can hear your voice. So please still talk to your patient. Please still reassure them. Awesome. Everyone happy with seizures? I am going through it quite quickly, but there's lots to cover in this session in an hour. But if you've got any questions, please let us know. Last call, a girl was having multiple seizures, 27, 1 or 2 minutes with 30 seconds in between. Cool. So again, you need to consider, are they pulling if they are recovering between seizures? If they're not, then we need to be upgrading that response to you. Yeah, cool. So again, like Paul said, if they've had a convulsion, you're always going to get a crew coming back you up, and then we've got different pathways. So if it's their first seizure, they're going to go into hospital. If it's not, then we've got pathways for epilepsy, for resolved convulsions that they can go down. So not all convulsions will go to hospital. A lot of them will recover at home, and it can be quite normal for them. But again, every patient's individual, and we treat the patient, we do not treat the condition. So, brain then, and stroke. So, we know stroke affects the kind of blood supply to the brain. We know what the brain does, we know different parts of it, but the brain needs a good supply of blood as well. So the brain cannot store glucose or oxygen, and it depends on a constant supply of blood, which is provided by two vessels, the vertebrae and the internal carotid artery that you can see in that diagram. The body's well designed, and it is connected, and it's all interconnected. So the arteries are interconnected to the cranial vault and produce a circle. So you can see both. Which is the circle of Willis. This is provided to provide an alternative route if one of those blood vessels becomes blocked. So even if one gets blocked, we've still got a supply of blood going up to the brain. So it is smartly designed. So that's what's kind of the anatomy and physiology of it. So what's happening during a stroke? So as you know, we can have a stroke or a TIA. It's a vascular problem to the brain that can last more than 24 hours. And a transemic TIA is resolved within 24 hours. So CVA is over 24 hours. TIA is resolved within 24 hours. And TIA could last minutes, seconds, or hours. So again, history is really important. By the time you get there, it may be resolved, but you need to get that history of them having a TIA. So what causes it then? So 15% is hemorrhagic. So there's a rupture in one of the blood vessels causing a bleed, causing swelling to the brain, causing that affects the neurons in that part of the brain. So it's bleeding in the brain, making it swell up and compress. Or we've got a clot. So a clot or a thrombus, which will cut the blood supply off to the brain. And this is the most common one, which is 85% of it. So 15% is hemorrhage, and then 85% is the most common, which is the clot. And again, remember, we've got that circle of Willis, we've got two arteries going up to the brain. So it's not going to be completely cut off, but it will have reduced blood supply going up. So types then, we've mentioned this already. Ischemic, which is the thrombus or the blood clot has broken free and causing a disruption to the blood supply. If you joined us in the cardiac session, it's all about that plaque buildup and that plaque being ruptured, causing thrombus. Then our less likely is the vascular, which is the hemorrhage, the bleeding in or around the brain, compressing, swelling the brain. Time is brain, so stroke, we know fast, we know the longer the brain is without oxygen or glucose or blood supply, the more damage that occurs. And we know the brain is really important, and the central nervous system is really important for us to function correctly. So it's a life-threatening condition. So signs and symptoms, we got, again, remember, it's the part of the brain that is affected, so it's not, or they're not always going to have these, but the common ones are limb weakness or numbness, weakness to a side of the face, difficulty speaking, so slurred speech, or unable to get the correct words out, or confusion. Clumsiness, so the perception, remember that part of the brain that's looking after perception. So they're trying to reach things, but they're not getting it, or they're falling more often. Difficulty in swallowing, sudden severe headache, confusion, change of emotional state. So remember, if it's affecting that frontal lobe and it's affecting the behavioural and emotional, then we may have a change of emotional state in that patient. Altered level of consciousness and incontinence. So it's really varied, the types of stroke or types of symptoms, and they can have unequal pupils as well. So how do we assess it? We've got the FAST test, which we're all happy with. We've been doing it for quite a while. So without kind of clot busting drugs for the management of acute strokes, it needs prompt recognition and prompt transport to hospital. So the FAST test, we're looking phasal palsy. So we've got a droop in the face, unable to smile, those sort of things that we're looking for. Arm weakness, so if they can raise both their arms up and keep them there, you can ask them to close their arms, close their eyes, you may see one drop. If they're lying flat, just up to 45 degrees. If one arm starts to drift, drop, fall, then they've got a weakness. Speech impediment, again, like I said, slurred speech, difficult finding the correct words, or confusion, then that's the three things we're looking for. And we're only looking for one of those for that patient to be FAST test positive. So they don't need all three. So only one of those will produce that patient to be FAST test positive. And remember, time is brain, so we need to get that information back to control to say your patient is FAST test positive. If they've got an existing weakness, would you still identify them as FAST positive, but with existing weakness? So no, if it is existing from a previous stroke and it hasn't changed, then you wouldn't. But if they've had a weakness and it's got worse, then you would. So if a weakness is there and it hasn't changed, and we've got history of that for the last few weeks or months because of previous stroke, then that's fine. But if they've noticed they're they've got slurred speech, but the speech has got worse in the last 24 hours, then they would be fast test positive again. Management then, not much we can do, to be honest. We're going to do our ABCD approach, fix anything that we find. We're going to give airway management or oxygen therapy if required. Sit them up if able. 30 degrees is the textbook, just allows that function and the blood supply to the brain. Reassurance is the big thing. Again, same as convulsions, the last thing that will go is their hearing. So talk to your patient. Loosen any tight clothing, monitor the patient's vitals, recovery position if they're unconscious. If you can do blood sugars, and all of you will be in a few months, once you've completed your CPD, then we need to rule out hypoglycemia. Cool. Everyone happy with that? Good. So they are the central nervous system or the nervous system, and those 3 common conditions that you may come across. What we're going to talk about now is the endocrine system. Anyone know what the endocrine system does? Hormones, yeah, good. So endocrine system is very much like the nervous system. Whereas the nervous system sends nerve impulses, which are fast, short lasting kind of messages. The endocrine system regulates the body, but sends chemical messages, hormone messages that are a little bit slower, but they last longer. So the endocrine system secretes kind of hormones, which will trigger changes in the body, which will allow. So we've got the pineal gland at the top, which sits just by the brain, just lower kind of part of the brain, and that will send hormone messages to tell the body to do something. Then we've got the thyroid gland going down. That regulates the thyroid, and it will regulate levels there. Then we've got the adrenal gland, which regulates adrenaline release. So that is our fight or flight response. Then we've got the pancreas that does insulin hormone, releases that, which regulates our blood glucose. And then we're going down to the testes and the ovaries, which is our kind of sexual organs, which does our hormones and our sperm and eggs, etc. down there. So it is very like our nervous system, but it's a little bit slower and it sends hormones instead of nervous neurons. So it's a slower response to stuff. And yeah, it acts as a coordinator of functions of the body. So why are we talking about this? We're talking about it because of the pancreas. Pancreas is really important, and it releases hormones. Anyone know the 2 hormones the pancreas releases? Insulin, yep. One other one. Anyone know? Begins with a G. Glucagon. Yeah, awesome. Good. So the pancreas will release those 2 hormones. Cool. So, where have I gone here? So what else does it do? It releases those 2 hormones which regulate the blood glucose. How it does that? So it's a complicated little diagram there. So I'll try and explain it to you so we know what's going on with diabetic patients. So if we have a big meal, we eat a good old big meal, that goes down to our stomach. Stomach breaks down that food, which increases glucose in our blood. That increase in glucose then is detected by the pancreas. So it sees that increase of glucose, pancreas sees that, then that will release a hormone called insulin. Insulin then will bind to cells around the body, which will tell them to take up that glucose, take the glucose out of the blood and use it. The main cell or organ that will do that is the liver. The liver will take most of the glucose out of the blood and change it into glucogen, which is basically the long-term storage of glucose in the liver. So big meal, increased glucose in the blood. Pancreas sees that, releases insulin. Insulin tells cells, mainly the liver, to take up glucose out of the blood. The liver will change glucose into glucogen, which is the long-term storage of it, and stores it in the liver, which will decrease glucose in the blood. So that's what happens when our blood glucose goes too high. Opposite effect when glucose goes too low. So again, the pancreas will identify glucose levels are too low. Instead of sending the hormone insulin, it sends the hormone glucagon. Glucagon will be released from the pancreas. That will bind with the cells throughout the body, asking the cells to release glucose. But the main cell or organ that will do it is the liver. So glucagon will tell the liver to change the glucogen back into glucose, which will send it back into the blood, which will increase the glucose in the blood. So it's good, it's longer lasting, and that's what the pancreas does, and it works all the time. So insulin will decrease the level of glucose, glucagon increases it. And throughout the body, we have multiple meals. We have breakfast, we have lunch, we have dinner, and our blood sugars go up and down, and that is what's happening. Insulin or glucagon is released, and just to maintain that. And that is called that negative feedback loop. So this is what you can see here. So this is that negative feedback loop. So glucose, we have breakfast, glucose will go up because we've eaten, we'll do a bit of energy, use it all up. Lunchtime will go up again, and then dinner again will go up because we're eating. At that same period of time, insulin will increase and then decrease, increase and decrease with the spike of glucose. And then glucagon is a bit of that relax, digest kind of hormone that just goes up and down nice and gently, just to regulate it. So that is the negative loop. So with a increase in glucose, we'll have a spike of insulin and a drop in glucose. Once the insulin drops, we'll have a spike in glucagon, etc. And that just maintains our blood sugar levels. That's what's happening in the pancreas, and that's why it's so good. When we're talking about diabetes, something has gone wrong in that system. So diabetes normally when it's chronically high blood sugars, and we've got two different types which we'll talk about. Major causes of premature death and multiple kind of conditions, such as it can lead to heart failure, stroke, kidney failure, and blindness. 3.2 million people have it in the UK. So we've got a kind of narrow range of 3 here. It says 3 here, so 3 to 5.6, what our kind of body likes it to be at. When we use our little machine, then we're aiming to get it between 4 and 8 when we're using our BM machine, which you may see. And that is what our blood sugars are if we're not a diabetic. If we're diabetic, that will change. That range or normal range will change for individual patients. So there are 2 types of diabetic emergencies that you guys will come across. We've got the most common one, which is hyperglycemia. And we've got the kind of more severe one, which is the hyperglycemia, which can kind of go into diabetic DKA. So different types then, and you guys know this because we have talked about this. So type 1 is the body does not produce the hormone insulin, so it can't regulate it, it can't bring it back down. So type 1 patients have to inject insulin at certain times for the body to be able to have that negative loop pressure. So that is what type 1 is. Type 2 is normally lifestyle kind of conditions or styles. So obesity is a big one and can be controlled through diet, weight loss and exercise. But this is accounted by 90% of diabetic patients have type 2, and that is normally the medication, so metformin or something along those lines. So type 1 is insulin, type 2 is non-insulin and medication or diet controlled diabetes. Complications then. So diabetic complications, we've got, like I said, the cardiovascular disease, renal failure. They can have acute conditions such as hyperglycemic comas and infections. They normally have a longer period of recovery due to infections. So how do we recognize it then? So hypo can be mixed up with stroke, or it can be mixed up with our drunk patients. So they may have weakness. They may have weakness in one arm. They may have speech. I'm having a stroke, or diabetic. I don't know, one of them. They may have muscle tremors. They may be sweaty. They may be cold. They may be clammy. But what is important is it is a sudden onset. So it will come on over an hour or so, or a little bit longer, or it could be a little bit less. We'll have rapid improvement with sugar. So if you're in doubt if it is diabetic hypoglycemic episode or if it's a stroke, then you can give them sugary fluid or food as long as they can swallow it. It will have no effect if it is a stroke, but it will have dramatic effect if it is a hypoglycemic episode. If it is left without treatment, then it will affect the glucose levels going up to the brain, which can lead to a convulsion or a seizure. So management of it, if they're unconscious, you just do your doctor's CABC and maintain that patient's airway. If they're conscious, then we just need to give them something sugary. Encourage to take their own medication if they've got glucose gel or glucose tablets. But if they haven't, then we just need to give them sugary drinks or a cup of tea with increased sugar in, and note the improvement. If they improve, then that's good. We're giving them high sugar. Once you've given them high sugar foods, you need to give them some carbohydrates, a jam sandwich or something, just to maintain it. Otherwise, you're going to have a peak of glucose, which will drop down again. So you just need to give them something else afterwards with a bit of carbohydrates in it, a slower release glucose for the stomach to break down. For hyperglycemia, this is when it's just too high. Glucagon isn't being produced, so they're very warm. This is where they have that pear drop kind of scent to their breath, fruity, sweet smell to their breath. If untreated, they will become drowsy, they will become unresponsive, which affects their breathing, and they become kind of agonal breathing or deep breathing, you would notice. This is gradual onset over hours and potentially days. This is down to the reduced or not the intake of insulin, can cause abdo cramps, nausea, vomiting, thirst, urination. But if this isn't noted, then this is can be a life-threatening condition. And again, very hard. If you've got someone with abdo cramps and nausea and vomiting, then that can be mixed up with a stomach bug. Excessive urination can be mixed up with a UTI. So it's really hard to identify in the pre-hospital environment. But again, treatment, we're not doing much for it. If they're unconscious, we're going to do our ABCD approach to that patient. If they're conscious, we're going to do exactly the same. Our ABCD approach. There's nothing we can do pre-hospitally for these patients. But we can measure it. So what we're aiming for in the average person is 4 to 8. With our diabetic patients, they may have a higher range, which is normal for them. So it's really important to ask them what their normal range is. Anything below 4, we consider as hypoglycemic. But if we've got a diabetic patient that is normally averaging 10 to 15 is their normal, then when they get to 8, they may be becoming hypoglycemic. So that's why it's really important to learn about your patient. Once again, we treat the patient, we do not treat the condition. If the patient's BM machine, or if you've got one in your team, shows low, that just indicates that it's reached the lower limit that the machine can record. And for the machines in WAS that we use, it's normally 0.6, which is low. If it's high, again, it's just reached the upper limit that it can record. And again, it is 33.3 for our WAS machines. But all you have to document is what the machine tells you. So if it's low, just put low. If it's high, just put high on your paperwork. And there are other devices that are available. So more common for type 1 diabetic patients are these continuous devices. So it records all the time, and they can have a insulin kind of flow or jet that kind of will send enough insulin to manage it. So it can be on mobile phones, or it can be on a separate device, and it continually monitors the glucose levels and delivers insulin when required. So you may see that out with your patients. So as Pauline said, I was a little bit ambitious on this session, but we've covered the kind of main ones that we needed to cover. So we've talked about the cardiovascular and the nervous system. We've talked about what's gone on in the nervous system and what is normal, the different parts of the brain controlling different parts of the body. We've talked about syncope and that fight or flight episode or response to a trigger, causing heart rate to drop, bradycardia, causing vasodilation, blood pressure, blood vessels to dilate, dropping blood pressure, reducing blood supply to the brain, which causes the patient to faint and reset. And we know how to treat that. Then we talked about convulsions and the different types. We've got the generalized or the focal. And again, it's depending on what part of the brain is affected. And that was shown on the EEG reading. So it's not always the whole part of the brain. And they can be simple or complex. They can be aware of it or unaware. But please remember, the last thing that goes is normally their hearing. So please still talk to your patient, even if they are having a tonic-clonic convulsion. Your voice will be reassuring for them. Then we talked about stroke, and and we've got the vertebrae and the carotid interior arteries that cause that circle, which always allows blood supply up to the brain. But we can have the ischemic or hemorrhagic stroke. Ischemic is the more common one, where we've got a plaque or a thrombus has broken up and got a clot in the brain, which is causing reduced blood supply to that part of the brain. Again, signs and symptoms depends on the part of the brain that is affected. Then we talked about the endocrine system, and that versus the nervous system. Again, does the same thing, regulates, coordinates the body, but instead of sending nervous impulses, it sends hormones and chemicals around the body. Nervous system is fast, short acting. Endocrine system is slower, but longer lasting. And it does lots of different things. We've got all the glands around the body that affects different parts. But we talked about the pancreas, which produces the two hormones, insulin and glucagon, which has that negative effect feedback loop, which regulates blood sugars within the body. Then we talked about diabetes and the two different types. Type 1, where insulin isn't working, so it can't have that feedback loop. So the patient has to inject insulin to control or regulate their blood sugars. And then type 2, which is normally lifestyle, diet controlled and some medication controlled, which will help the pancreas kind of regulate their insulin. And we talked about the different presentations, hyperglycemia and hyperglycemia. So hopefully you found that beneficial. I am going to stop. It's 3 o'clock because I only kept you for an hour. So has anyone got any questions on those two conditions? Are these sessions recorded? Yes, we are going to record. They are being recorded. I'm going to stop recording now. Thanks for the reminder. And I have got them. I'm going to upload them